In this session, we perform the meta-analysis. We discuss all the relevant insights in conducting a meta-analysis. So enjoy this show and remember to like, share, and subscribe.
So, guys, today we'll be talking about meta-analysis. We're going to be discussing about meta-analysis in depth. Now, this is one part of research that, particularly in a systematic review, that has really been getting people so confused. People are so confused about how to do or perform a proper meta-analysis. And it's something people find very difficult. But in this session, we're going to dissolve it and make it very, very decent and well explanatory. So when you're listening or you're watching the whole entire demonstration, then trust me, it's going to be a very, very phenomenal one. Remember, meta-analysis is one of the quantitative approach. That seems to be the only quantitative approach for performing the synthesis in a systematic review. So let's get started and dive into it. My name remains Innocent David. I'm the facilitator for today. So let's get started. So one thing we're going to do today is we're going to have a normal look at what our outline is going to look like. In our previous session, we've already defined what the meta-analysis is, but we're going to have a redefinition of that also. Then one thing that is also very vital in data synthesis, particularly whenever you're performing a meta-analysis, is to understand the effect models, right? So we're going to explain all the effect models in meta-analysis. Then we'll talk about some of the types of outcomes, because it's very important for you to know the types of outcome. Remember that one thing we talked about in our previous session where we discussed about data synthesis was that we did mention that when they are qualitative outcomes, right, we go for narrative or thematic, but then when there are numerical outcomes, we go for a meta. But now we need to now understand, are there further types of outcomes that you can extract? So think of outcomes as some of those information that you're going to extract from those primary studies that you want to use in doing your systematic review. So we'll have a very detailed, bright example about some of this information. So it wouldn't end there. We'll go further to talk about some of the effect measures. What are the key effect measures performing a meta-analysis? We really need to understand it because it is going to form the bedrock of most of the decision we'll be making in terms of our analysis, in our meta-analysis. So if we don't have an understanding of the key effect measure, then that means we're going to have a wrong interpretation and we're not going to do the proper analysis. So when we've digested the type of outcomes, we reflecting what we have in our review manager, then we'll talk about some of the key effect measures. And I'm going to also elucidate on the step-by-step guide that we need in conducting our meta-analysis, particularly using the review manager. Remember that there's lots of tools out there that you can use in performing your meta-analysis. Tools like SPSS, can use SPSS means statistical package for social sciences. You can use the R programming software. You can use Python, and you can also use Revman. There are also other statistical tools also that are available for you to perform your meta-analysis. So we're going to, in the sake of this session, we're going to be using the review manager, which is short formed as the Revman. So I'm going to walk us through the interface for Revman, what it looks like. I've already got one installed. So you need to have Revman installed in your laptop for you to be able to perform that. Then I'm going to also explain what we mean by forest plots and also what we mean by publication bias. So when we talk about forest plot, what do we mean? How do we represent our analysis? Particularly in our meta-analysis, we use what? Forest plots. Then we're also going to talk about publication bias, and which is represented using what we call funnel plots. How do we get to perform our publication bias? So we're also going to explain that in details. Then we're also going to explain how to interpret our meta-analysis results, right? That is also going to form part of our discussion today. Then we need to understand some of the various measures. How do we know what is what? So let's assume you're just a beginner and this is your first time of doing a meta-analysis. So this will be the right place for you to, or right avenue for you to understand how to interpret the meta-analysis results. Then we're also going to look at other components that we might not get to really cover, but we also need to explain them, and then some of the considerations we need to put in place before starting a couple of practice exercises for anyone out there who has bought this course or who is listening and is interested in starting their meta-analysis. So this is going to be a very brilliant session for us to get these things in place. Now the game begins. This is where the game starts properly. Now we go back to understand what the meta-analysis is. What is the meta-analysis? That is the question. Now when we talk about the meta-analysis, we're talking about a statistical technique. That's definitely what we're looking at. We're talking about is any type of statistical technique that tries to combine the results from multiple studies, to derive an overall effect. So remember that we picture meta-analysis in the sake of we performing, trying to gather primary articles together. Then sometimes when we gather these primary articles together, some of them might have differences in terms of what they're reporting. In that situation, we don't perform a meta-analysis. We try to write up those situations from those individual primary studies. But now, in the sake of a meta-analysis, what we are interested in now is we're interested in those numerical attributes from those individual studies, summarizing them. Let's say, for example, we're collecting the prevalence of malaria across 10 studies. We're only interested in those numerical representation of the prevalence of malaria. So we collect them together across several geographical areas in Nigeria. Then we summarize it to have an overall effect to see that, therefore, the average prevalence or the mean prevalence of malaria in Nigeria is 40.5, having collected this from all the studies on prevalence of malaria in several parts of Nigeria. So this is just a clear-cut example that I'm giving to you. So this is what the meta-analysis looks like, where we try to combine these results from multiple studies. Remember, along the line, we're going to be discussing a whole lot of things about meta-analysis from different angles, but it's very imperative and important for you to have a very good understanding of the definition so that while you move ahead in these areas, you already know what you want to do. In short, as a matter of fact, you don't really need to be so good in statistics for you to know how to perform a meta-analysis in a systematic review. Remember, in a systematic review. But still a bit of information around statistics to get these things done. You need to know how to interpret information and all that. They are very relevant in this particular scenario. The next thing we're going to talk about is what's the purpose of the meta-analysis? So we already answered that in our division here because we just want to provide a single effect or a single estimate. Because if we want to know the prevalence, let's say WHO is giving drugs on malaria to several countries in Africa, right? So in Nigeria, now when they come to Nigeria, now how do they get information about the state of malaria in Nigeria? Is by gathering a study that was conducted in several parts of Nigeria, maybe a state like Imo State, Kano State, Taraba, and all that, then summarize. That's where a meta-analysis comes in. So that is the purpose of a meta-analysis, by summarizing all this data to give us one overall estimate of prevalence of malaria in Nigeria so that WHO, through their clinical decision or their policies, can know the amount of drugs they will allocate to Nigeria. This is just a clear example of the purpose of the meta-analysis, because if we don't use a meta-analysis, then it will be difficult for us to do or summarize that effect measure. So this is just in terms of the descriptive meta-analysis example. In terms of an intervention, it's also important for us to know that, because one might be asking, can't we just collect all the prevalence and do a mean average? In terms of an effect of intervention meta-analysis, in that situation, we might need to now try to understand some of the association between an intervention and a control group. And this is not something you can do descriptively. So it holds a lot of water for the purpose of what? A meta-analysis. So giving lots of examples when I talk about malaria. So another one is maybe if we're trying to combine the results from various studies to determine if a new medication reduces blood pressure. So this is what we'll be doing severally along the line, where we'll be trying to compare one or two interventions or an intervention against the control or against other techniques to know which is more effective. And that is where the meta-analysis what comes in, particularly for the example we're going to be using today. Now, if you are starting your meta-analysis, this is something you will need to understand that is very, very important for you to know, is that whenever we are performing a meta-analysis, we're interested in two particular effect models, which is what the fixed effect model and the random effect model. So what do we mean by the fixed effect model? Because somebody might say, oh, we just finished talking about defining meta-analysis and we jumped into more effect models. Now, remember that when I was explaining, I did explain that we are collecting studies from different places in Nigeria on prevalence of malaria. Now, see it from this angle that some of those studies now, it's possible that they have the same design or they have the same characteristics, they have the same reports for prevalence of malaria. In terms of prevalence, they all reported it in terms of percentage, right? Nobody is reporting it as 1 point or in decimals, 1.04 or whatever. Now, what does the fixed effect model mean? The fixed effect model illustrates that if all the studies are actually reporting at the same, or they have all the same characteristics, the same sample size, technically everything about the studies are the same, but different location now or different therapies. So it means that we might likely need to use what clinical notes, the fixed effect model. Don't worry, I'm going to also show you the practical how we can actually impede it. This is just almost simple. You just to set it whenever you're performing your analysis so that it makes a lot of sense. So that's that. So for the random effect model, it's now the contrary of the fixed, where maybe there are varying estimates, the sample size are large. So one of the studies, the sample size is 2,000, the next one is 100, the next one is 60, the next one is 800,000, or in terms of the outcome of reporting, there is significant heterogeneity. Now, whenever I use the word heterogeneity in this tutorial, I'm trying to talk about what differences. There are significant things that are not alike. That is it. So in the session of an example now is when we are trying to study exercise program within different samples. So it could be within adults, within children, within mid-level youth and all that. So in that situation now, we can't use a fixed effect model because there are differences in this study. So we'll go further to give us kind of a baby example of these differences in the effect model. Now imagine you're a 10-year-old, right? So and you're trying to figure out which ice cream flavor is the best. Maybe you've asked some of your friends to give you their opinions. But then each of them has a different idea of what a good ice cream means. Now, this is what fixed effect model means. Now, this is just like saying that everyone now is testing the same exact ice cream. So they all should give you the same opinion, right? So if all the ice cream flavors are actually very similar now, let's assume now. So that means we're expecting them to agree, on which one is the best. So if you average all the opinions to get one result, right? In all these things, you see that everything is the same and they're likely going in one direction in terms of agreement. So it means that we'll use the fixed effect model. So I'm sure pretty well that we've already by default understood what the random effect is going to mean, because it's not going to be the opposite here, where you just like say that everyone is trying to test different type of ice cream and each one has a different opinion about what they like. So because everyone now is actually, their taste now is different, you can't expect everyone to agree. So that means you need to take account that there are some differences in the opinion and you need to find the best overall answer, if not the best. So this is also what the random effect meta-analysis or the random effect model illustrates. So I would say in simple terms that if the studies are very similar, right, then like just like trying, everybody now is trying the same flavor. You need to use fixed effect model. But if there are differences, you have to break up with that particular what study. Now, there is something very, very, very important I will need to be talking about now in terms of these types of outcomes. Now, talking about the types of outcomes, first of all, I think we need to focus on these first two. These are the main categories of the outcome. Now, the last three that I actually listed here are only interested in the interface for meta-analysis whenever we're making any selection. But for the sake of this lecture, we're just going to be looking at this first two, which is whenever we're talking about the dichotomous outcomes, remember, if you've learned statistics for healthcare professionals or whatever, it has been mentioned to you that there are two types of outcomes. We've got we have the quantitative and qualitative outcome. So it depends on how you measure it, right? So if there's any type of outcome that is coming in categories like yes or no, in that situation, particularly if it's binary, it's what a dichotomous what outcome. So what are we saying? The point is that before you start your meta-analysis, right, before you start extracting information from those studies, you need to know that your type of outcome is going to determine the type of meta-analysis that you're going to perform. So if you have continuous outcome, that means you're going to have what you're even going to extract is going to be entirely different compared to who is using what, or who study has a what dichotomous what outcome. But what we need to understand is that for both dichotomous and continuous outcome, it's possible that in our study we can have included studies which are reporting outcomes that are also both dichotomous and continuous. So that means even in the example we're going to illustrate now, we will find out to see what the outcomes of those studies means. So for example, if I'm going to just say an example of continuous outcome, now let's say you're talking about blood pressure, is the outcome, if the outcome is in terms of 100 millimeter mercury, 20 millimeter mercury, 40, whatever, right? In that situation, is numerical, right? Or 40.1 and all that is numerical. So it's a continuous what? Outcome. And that means there are some certain parameters that will be extracted from what? From the articles. Contrary to when, let's say, we are collecting a study and the outcomes are dichotomous, and there are some certain parameters we're going to be extracting, which is actually very, very what? Simple. Now, in terms of the ORE and variance, so the explanation is that the ratio of observed to expected events are still using the rate studies. So whenever we're trying to perform any sort of prevalence studies, right? So we usually use the OE and variance. So remember, I went to use this whenever we're comparing observed versus expected events, like example on how effective is a new intervention in reducing hospital admissions, right? And also in terms of the generic, is a method that is used in combining studies with different effect sizes using inverse of variance. We can also use it for what? Prevalence studies. I remember that we use it whenever we are combining different effect sizes or measurement things from various studies. So other data, we can also have other data depending on the flexibility or depending on the nature of our research question. That's going to inform how else we're going to set everything and get it going. So the question now is, what are the key effect measures whenever we're performing a meta-analysis? What are the key effect measures? Now, one of the key effect measures that we have is what we call the odds ratio. Now, think about the odds ratio as maybe we're trying to compare the odds of an outcome in the treatment group versus the control group. Remember here, the key term here now is what? The odds of something happening in either of the groups, right? So, example now is just like saying If the odds ratio is 1, that means there is no difference between the groups. But then if your odds ratio is greater than 1, then it means that maybe the event is more likely to happen in the treatment group, or why an odds ratio that is less than 1 is showing that it's less likely. So what are some of the examples of some types of research questions that we could need to know if we're going to use the odds ratio? It could be whenever we're exploring a type of question like knowing what is the effect of a vaccine on infection rates. So now, just like seeing what are the odds of getting the flu now among vaccinated individuals compared to unvaccinated ones. Remember that by me talking about some of these effect measures, it's just all about selecting it. You just select you select it and that's it. Right? Another one now is smoking and lung cancer. So we can be asking a question now, which is very simple. What are the odds of developing lung cancer in smoking versus non-smokers? So we can take the OR, which is going to help us to quantify smoking as a risk factor. Now, we also have another example here on drug efficacy in disease remission, which we can actually understand here and put also into practice, and that's also quite very simple. Now, the next effect measure that we will look at is the risk ratio. And the risk ratio, sometimes we can actually address it as relative risk, because most of the studies that we'll be conducting, we might need to use the risk ratio or the relative risk. And it's just like we're trying to measure when, to compare the risk of a particular outcome occurring in one group, like a treatment or intervention group, to the risk of it occurring in another group. Remember, it's sometimes we do say that it's often used to gather information on the effectiveness of preventive interventions. And in simple terms, whenever your risk ratio is 1, it means that there is no difference in risk between the two groups. But whenever our risk ratio is greater than 1, then that means that the outcome is more likely particularly to occur in the treatment group, while the risk ratio of that is less than 1 means that the outcome is less likely to occur in the treatment group. So I have a couple of examples here of some of the research examples, where we can actually identify this. Don't worry, we're going to also show in details how we can actually get these things done, particularly in terms of vaccine effectiveness, trying to know the risk of contracting measles among vaccinated children compared to non-vaccinated children. Remember that here the key word here is more like risk. So it's the risk ratio that we're going to bump into, because that risk ratio is just trying to demonstrative vaccination reduces measles risk. Now, another example there is the heart disease and diet, right? So if we're interested in knowing the risk of developing heart disease in individuals who follow a Mediterranean diet versus those who don't, remember that it is that risk. It is that risk. So we just want to know if the diet lowers heart attack or heart disease attack. Now the next part now is the exercise and diabetes prevention. So if we want to know the risk of developing type 2 diabetes in individuals who exercise regularly to those who doesn't, so we need to use we need to use the risk ratio to understand if this can indicate the protective effect of exercise. So let me just throw more light there. All I'm saying is that whenever you're starting your meta-analysis, choosing your effect measure is more than important. Sure, that is more than important, particularly when you've had a very detailed interpretation of all the studies and what the research question is talking about. So somebody might be asking now, what is now the difference between odds ratio and risk ratio? Now remember that in terms of the odds ratio, you try to by comparing odds of an outcome occurring in one group versus another, right? Whereas in risk ratio, we're trying to compare the risk of an outcome between two groups. So remember, this is the odds of an outcome occurring in any of the groups versus what outcome, whereas this is what comparing the risk. In terms of when to use it, so we use odds ratio particularly whenever we're doing a case control study, right? And when the outcome is very, 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 very rare. Whereas we use the risk ratio maybe in cohort studies or randomized control trials where the outcome probability is highly, really highly what needed. So this is the statistical illustration of the odds ratio, where we have now beautifully showed that when the OR is greater than 1, outcomes more likely in treatment group. And if the OR is less than 1, well, the first one is greater than 1. If the odds ratio is less than 1, then it's less likely in the treatment group. So the same thing also applies for the risk ratio. Whenever it's greater than 1, increased risk in treatment group. Less than 1 is decreased risk in treatment group. So what's the suitability for meta-analysis here is that for odds ratio is good for rare events, and whereas and that is usually when the odds interpretation is simple, and most times we can even overestimate effect if outcome is common. Whereas for the risk ratio, it's preferred when outcome probability is very, 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 very clear, and yep. And again, also remember whenever we're trying to provide the direct measure of the relative. So let's look at other effect measures outside of the risk ratio and the odds ratio. So we have the mean difference, right? Now, if you remember, these two, the odds ratio and risk ratio, are used largely for dichotomous outcomes. Are you following? So they are used largely for what? Dichotomous outcomes. Whereas in terms of the mean difference and the standard mean difference, they are used for what? Continuous outcomes. So the mean difference now is just like an effect measure used in meta-analysis whenever we are trying to compare the average outcome of two groups. So that is when we use the what? That's when we use the mean difference. Remember, for example, now let's say we're trying to understand the blood pressure reduction based on a particular medication. Here now, we're not looking at yes or no compared to the previous effect measures, but here now we're dealing with numbers. So we're trying to understand the mean difference now of systolic pressure between patients taking a new hypertension drug, right? And this is what's numerical, so we need to pick it up. Now, also, let's say we are looking at weight loss program effectiveness, right? We're trying to know the average weight loss difference between individuals enrolled in a structured weight program. So in this scenario as well, we need to use the mean difference. Now, beautifully well, I'm someone that I really love comic. I love comics so much. Now, to talk about standardized mean difference, it's not going to be complete without that. So that SMD, so it is a meta-analysis when the studies measure the same outcome, but use different scale. So that is when we use the standardized mean difference. So an example is maybe let's say we're looking at cognitive function test, trying to understand what is the standardized mean difference in cognitive function scores between patients receiving cognitive behavioral therapy and those with no children. In this situation now, we have all these studies and they seem to be similar. Then we use the mean or the standard mean difference. Now, another information there is the quality of life, right? Another study on quality of life post-surgery, where we're interested in life. Well, yeah, in terms of quality of life for post-surgery, we're interested in quality of life scores following different types of surgical interventions for back pain. So we look at the different questionnaire, which may be used across these different quality of life questionnaires may be, used across the study. So SMD now, this standardized mean difference makes it what? Very, very what? Decent. So we go ahead to talk about the differences between the mean difference and standard mean difference. Here, if you talk about the definition here, we already said that, the absolute difference in means between two groups, right? Whereas the difference in means analyzed to account for differences in what? Measurement scale. So when do we use the SMT and MT? It is usually what? When the studies use the same outcome measurement scale, right? So let's say we want to perform a study on Alzheimer's disease for managing depression. It will be very difficult because in that situation now, we need to do what? We need to do what? Actually assign either to standardized mean or mean difference. So second example there is what? Let's say for the mean difference, we're trying to know what is the mean difference in weight loss after a 12-week diet program between two groups. So these are actually the example, right? And also maybe we're looking at what's the SMD in exercise performance improvement after a fitness program. So the idea here is that we use the standardized mean difference if we want to have several measurements, units of measurement. Remember in the first example where I talk about the prevalence of malaria. So all I'm saying is that in that scenario now, some studies can be reporting their unit of prevalence as decimals, some others in percentage. So using the standardized mean difference means now I have to convert it to what? I have to convert it to one singular mean. Then I will now do the what? I will now do the whenever I convert it to one singular unit using what? SMD, then I will now do the meta-analysis. So yeah, gradually we are getting closer. So I'm just going to show us a bit of what the software looks like. This is Review Manager. I have got it on my screen, and you can see 5 everywhere. Now, before I go further to show that, I've just quickly opened it. So I'm going to ask them, so how do we get started? So to get started, first of all, we click on Project. We open Revman, we click on Project. Then we import the data. We add studies by entering data on the study characteristics. We're going to also show that. Then we select the type of model we're interested in. Is it fixed or random effect? Then straight up, we select our effect measure, whether it is odds ratio, risk ratio, mean difference, or standard mean difference, depending on the type of data that we've got. Then we run the analysis after we've done that to generate the summary effect where we can actually get our forest plots and all that. Then we interpret the results. So this is a very, very, very simple aspect of what? Starting or getting started with what? Revman. So before I also open that back again, I'm going to explain some of the interfaces that we've got there. So one of the interfaces that we've got there is what? Protocol. It has what we call the protocol, because Review Manager is a tool that we use it in right now what systematic review, usually owned by what the Cochrane collaborator group. So it is now up to you that whenever you're using it, you can use it as a what? As the non-Cochrane mode, particularly whenever you're installing, because most people that will be installing this application after they must have heard from me, you get to a point where you have to select if you're using a Cochrane or a non-Cochrane mode. That means you have to do what? Disable the Cochrane and choose non-Cochrane method. So we've got categories of studies, we've got data and analysis, forest plot, tools panel. All these things are all what founded there. So I'm going to also show an clear example of this interface. So before I explain the forest plot. So, okay, so I'm going to now, this is what we're talking about. So when we open the Revman tool, right? So the next thing we're going to do is we'll close this. Once we close that, we'll click on File, we'll click on New. Okay, so I'll close that and secondly click that. Then here we're going to click on Next. Then we need to now choose the type of review that we're interested in. Now, this is just like a walkthrough on the layout of the Revman tool. Now, looking at the Revman tool, we've got several types of reviews. We have interventional reviews, we have diagnostic accuracy review, we have methodology review, we have overview reviews, flexible review. Remember that we can always do an umbrella review, right? So they can actually come here. And sometimes you might not really like what you have. If you have something unique in mind, you can always put it. So I'm going to leave it with intervention review. So I'm going to click next. Now it wants me to put in my topic. So I'm going to be giving an example with the topic of locking fixation. So here, remember, I'm just going to show. So locking fixation for what? Now this is the topic here. I'm just going to bring that up. Effective locking fixation in treatment of what? Humeral fracture in patients. Now when you look at this now here, the review manager, the treatment of what? Humeral fracture, it can't enter here. So I'm going to take it out from here. Locking, if you have topics like locking fixation in versus another type in managing this, you can actually put it, but it's not going to enter here. But I think it's going to enter here. I will say locking fixation. And we can look at that again in treatment of humeral fracture. So that's the health program. Humeral fracture. In what? In patients. In adults. In our inclusion and exclusion criteria, we've specified that. Well, I don't think this is a big deal. Now, if it's that all these things doesn't fit into your type of review, you can just write it here. It doesn't mean anything. You can just put it down here. So I'm going to click on next. Now, remember, if we go back to our slide here where we were talking about some of the interface, we did mention that it contains the protocol phase, right? And also the full text phase. Now, but in this terms of the protocol, if I'm going to come here and click on protocol, if I click on finish, so it takes me in here. But what happens is that there are a lot of things I might not be able to access, because remember, whenever you're writing a proposal, what are the things that are usually very important in your proposal? The proposal, you got your introduction, particularly in your proposal. You've got your rationale, you've got your methods. Now that is where almost everything ends. You can't have the results in your proposal. I hope we can remember, right? You can't have your discussion of results, right? You can't have all these things or having conclusion based on results. You can't have all these things in your proposal, because remember that your proposal, you're still proposing. So that means you've got limited information to just like. So these are just the only ones you're going to have. So now, what are we trying to say? When you look at this here now, you find out that it restricts us from the results, it restricts us from the discussion, it restricts us from the other things like author's conclusion, right? Because it's at the proposal stage. So what we are going to do now is, because we are already past the proposal stage or the protocol stage, we are going to change that into full review. And to change that, we'll click here, we'll click on properties, then I'll change it to full review, then I'll press okay. Now you see, immediately I've done that, we now have full access to technically everything that we didn't have access to. So when we click on main text here, you see that we can now do we can click on all these areas. Now remember that this is me explaining the interface of the review manager. The review manager, we use it in performing the analysis of our study. And you can also use it as if you're using it as a Cochrane collaborator, then it means that several persons are logged in here. Anything that you're doing on this document, your colleagues are also what seeing it. For the sake of this lecture, what do we really need to know? The review manager provides us with all the domains of our manuscript. I could come in here and I'm going to search for prevalence. Yes. So let me just give us a picture of the manuscript that we got published. Sorry about this. Cool. Now, if you remember this, my recent publication, you find out that you look at the domain, introduction, methods, search strategy, you've got study selection, extraction results, then characteristics of the included studies, down to QE, quality assessment, discussion, and all that. Now, have you seen it in conclusion? Author's contribution and all that. Now, take a look at this now. Let's look at it. This is going to serve as the introduction, right? So we'll talk about the background. We're technically talking about the introduction, right? So that's not the big problem. So from here now is the methods. So we have our search strategy, search selection criteria, and all the other pertinent information. Then we have our main results here. Then we have our conclusion. So this is for the abstract, right? And that is still what is applicable here. So this is the background, introduction, methods, symptom results, discussion, and of course conclusion. Again, implication or recommendation, whatever thing you might want to call it. Now, what point are we trying to drive home? The point we're trying to drive home is that the review manager provides us with what? This access. So if we wanted to report using the review manager, we can do what? We can now adopt this checklist and start writing. Are you seeing it? We can start doing what? Writing what we want here. And at the end of the day, when we're done, we can do what? Share it with our colleagues or co-collaborators or partners, people who are actually engaged in what we are doing. So this is just a tip of the iceberg about the what? About the interface of the review manager. Now you see, I can actually edit this. I can put this back. I can edit the title. This is just a template. I think that's the best word to use. It provides us with what? That template that we need. So there are also other areas, other things you can perform here or here. I don't want to explain all this. When you come to the results, this is where we're going to be working. Right? Cool. And also here. So if you want to insert tables, you can actually insert tables here, tables for activities of included studies, tables of some of our findings, additional tables. Then if you want to, remember that here, let's return back to the slide. Remember that we talked about what? Here we said, once we are done setting it up, we need to do what? Add studies, right? We need to add studies. And to add that studies is going to be performed what? Here, in this what area. And I'm going to show us what? Actually a clear example of how we can do that. So for us to add studies, it is going to be done what? It's going to be performed what? Here. Then we can now get our comparison group, get our outcomes, know if it is continuous or what? Dichotomous. So moving forward, before we move ahead, let's know what a forest plot is. When we talk about a forest plot, it's just like a graphical representation of each study's effect size and the overall effect. We're also going to interpret this, don't worry. And it contains some of the things that we can see here. One of the things the forest plot contains is what? The square diamond, which is this, or the diamond here. This is diamond, right? And it contains horizontal lines and it contains what? Squares. Now the squares now represent what? The size and weight of each of these studies. So it means that this study has more weight than this, and it has more than this, and this has more what than this. Now, when we talk about the horizontal lines, it is the confidence interval between the what? The study, both the upper and the what? Lower limit. Alright? So the confidence interval of each study is shown with the what? With the horizontal what? Lines. Whereas the diamond here is what is going to tell us the overall summary. Where does this graph, what does it favor? What is being favored? Is it the treatment group or the effects or the experimental group? Whatever thing you want to call it, treatment group or experimental, or I want to call it the comparison or other interventions or placebo. So these are the things that this diamond helps us to illustrate. And it's just like the position of the diamond is relative to the line of what? Effect. So anytime the diamond does not cross the line, that means the result are statistically what? Significant. Because it means that it is statistically significant here if here is what? Control group. It means that it is significantly effective to control group or significantly effective to what? Whatever group, intervention group and all that. So that is that. So let's look at what publication bias. So when we talk about publication bias, it's something that occurs whenever we, the studies are actually showing significant results, whenever they are more likely to be published. So skewed meta-analysis, skewing the meta-analysis. That's whenever we talk about publication bias. So, but we won't really be going so much in deep terms into that actually. But all we need to know is that we use something like a scattered plot, like what we call the Eggers test, to perform what funnel plots to reflect particularly if there is asymmetry or perform statistical step. So yeah, we also have the more detailed example about this. And an example of this is a meta-analysis of exercise studies where only positive effects on weight loss are published. So publication bias is just the way we understand it, in the sense that in our last session we did mention that it could be when maybe there is now bias in terms of what publication. So just lately I was asking my systematic reviewer if we could publish a certain work on among academic staff. And she did mention to me that some of the data collection process were a bit influenced. And that means that, but I now asked the question, what's the overall finding of that particular paper? Was it effective? She said yes. I said, okay, cool. Is there any need publishing it? That's publication what? Bias, because already we now have the ones we're interested in. So the same thing holds also publication bias because it's represented with the funnel plot. But this is where we have an example of the approach in performing it, where we need to do a scattered plot for effect sizes versus study precision. Then we need to do what? Enter the data into Revman, which is the first thing. We go to data analysis, select funnel plot from the tools. Interpretation is that symmetric plot suggests low publication bias, but why asymmetric do indicate potential bias. So this is just like a plot now showing asymmetry, right? Where it may imply smaller studies with negative results, which are actually published or unpublished rather. So we'll go into some examples where I will now have to be explaining in deep details with the example we have, because one thing with statistics is that statistics is almost impossible if you don't practice. And that is what we need to do, have our own practice. Now, I think we are going to look at that before we talk about how to interpret it. But let's just have a snapshot of what it's all about. So, how do we interpret our meta-analysis, particularly when the range is within which the true effect likely lies? That's for the confidence interval, usually at 95%. And for the p-value, remember that it is what less than 0.05 to show that it is statistically what significant. And also, whenever we have the more bigger squares, which is larger effect sizes, it indicates what more like a stronger effect of what should be viewed in the context. So it means that even if we were to do stuff like sensitivity analysis, we wouldn't really have to remove those studies because of their impact. So risk ratio of 0.7 with 0.5 to 0.9 confidence interval shows the significant protective effect. Now let's go on to look at other interpretation or other further clarity. Is that our heterogeneity is what is measured with the what I squared. I squared test is understood with what we call what heterogeneity. And whenever it is lesser than 25%, that means the studies are actually what similar, they are homogeneous. But whenever the I squared characteristics is pegged is greater than 75%, then it implies that the studies are varied and this random effect model that might be what suitable if you haven't checked. So example is the meta-analysis of showing moderate effect size R equals to 1.5. So whenever meta-analysis is showing moderate effect size R equals to 1.5, so for treatment effectiveness. So I'm going to take us along with lots of what explanations and details so that we'll get to do what? Get all these things what? Very, very, very clear. So what are some of the considerations whenever we are starting our meta-analysis? First of all, we need to do what? We need to define clear what? Objectives, which is still essential in our systematic review process. Then we need to actually identify our inclusion and exclusion criteria, because this is very important so that we know when our population group is either heterogeneous or what? Homogeneous. And again, we need to test for what? Heterogeneity, which is the I-squared test statistic to measure the consistency across the studies. And we need a model. We need to choose either fixed or random effect based on the heterogeneity. All right, cool. So what are also other additional components? Like I said, heterogeneity testing. We can also perform what we call subgroup analysis. If we have enough data, we can actually do subgroup analysis. And we can do sensitivity analysis, which I talked about here now, which is test for robustness. And these are all the things, as well as, for example, in the meta-analysis of diabetes intervention, subgroup of by age to see if effects vary. So what are some of the summary of our key points in our session today, doing meta-analysis? The summary of our key points are that firstly, meta-analysis combines data for a summary effect. Secondly, we need to also understand that some of the tools for entering data, running analysis, and visualizing results are tools like R, SPSS, and Python. So also forest plots and funnel plots are also very important because of they are key in making our graphical interpretation and publication bias as well, and increasing what and interpreting what results. Remember that also another thing we do perform is what our risk of bias, which we have already explained in our previous session. So we've got a practice exercise there for us. Now, to get started, we need to just pull in an example. Now, how do we start? I'm going to open this document, which is going to serve as our working document. So here, we're interested in the effectiveness of locking fixation in the treatment of humeral fracture in patients. Now, somebody might ask, what is locking fixation treatment? Now, let's just ask Google that question before we open it. What is? So we're going to ask that question. No, it is very simple. Locking fixation is just like a surgical technique that uses plates and screws to stabilize fractures. and promote what healing. So let's have an understanding of what we are doing. Because if you don't understand what you're doing, it's going to be really very problematic for you. So that is it. Now, we've already opened our working document. Now, let's look at this review. Remember, we've already talked about how to write technically in the beginning stage. So we've written our background, right? Cool. So this is where we provided the rationale. Okay. So if you're wondering why we didn't number it, it's not because so if you're asking why we did number it rather, so it's because of the referencing style that we chose or adopted. So yeah, we've got our introduction, we've got our search strategy and selection criteria. That deals with that. We have our risk of bias, which is known as the quality assessment. And we have the what? We have the data extraction and the data what? Synthesis, as well as the what? Results. Now, let's get to understand something. What is the first thing we do when we start a systematic review? Yes, it follows a reproducible guideline. Correct. So it means that we've done our search, and we've done our quality assessment, and we've done our data extraction. So that means we need those 6 studies. So I'm going to those 7 studies, right? So based on the Prisma, I found 1690 papers, remove 733 duplicates, screen 957, excluded 951, assessed 396 reports, and they are still here with me today in my data bank where I extracted them. So these are some of the reasons for exclusion. Remember, I already talked about this in my previous session. Then studies included in the review is this. Then we'll now add again an extension here. So we're going to call this studies included in meta-analysis, okay? So all these are going to form part of the included studies. So then the next thing we're going to do is to get the 7 papers. Remember that we've already drafted the characteristics of these studies, and we explained that in our data extraction process. So if you haven't seen this, you can actually go back. We also showed the advanced data extraction process also. Now, the problem that is faced with us here now is the meta-analysis, which is going to be the synthesis, where we are going to ascertain we're going to try and ascertain the meta-analysis of locking fixation techniques in managing humeral fractures compared to other placebo. Now, how do we get going now? We have already, I'm back to the Revman software, where we've already explained to us how to get our title in, how to move from protocol to full text review. Now, the next thing now is, remember that we are here. To have an idea of what we're doing. So we are here, we've opened and created the new file. The next thing is for us to add the studies. Now, how do we add the studies? Now, first of all, here are the 7 manuscripts. I'm going to open them quickly. I've opened the first. I've opened the second. So I already see it's clear. So 1, 2, 3, 4, 5, 6, 7. Now these are our 7 included studies. Now, what is the next thing? What's the next thing we're going to do? The next thing we need to do is to list all the outcomes, first of all. Now, how did we get the outcomes? How did we get the outcomes? We got the outcomes from extracting that from the what? From the characteristics of the what? Of the included studies. So you're going to remember here, we have the what? The outcome of interest. So not all the outcomes we are taking. Like when we look at constant this, we go down, we see it here listed here by 0. We also go down. I think that is that. Okay, we see it here by Platt. And also see it what's here also by Grayson. So now, cool. So having that in mind, so we return back to our review manager. Then we go over to what? Adding studies. Please pay attention here. We have opened this. Then we want to do what? Add the studies. Remember, we are doing what? We are adding the studies. We are just adding all the studies because we need to enter the data from the studies. So we need the studies added before we start performing our meta-analysis. So let me add the studies before we even what get going. Now remember that these are our what? These are our papers. So I wanted to add, we could have added this with the year, but we are still cool with this because we don't have any same study that is appearing maybe here. We have another chance study. Here would have needed to call the function of the year. So I just copied that. So I go to Revman. I'm going to come down to studies and referencing. Now, let me explain this. When you open the Revman interface and click on review, full review, you have what we call included studies. What are the included studies? The included studies are the studies that we are going to use primarily to address the question, the primary question. Because sometimes you could bring in excluded studies and perform publication bias, right? So that's another one altogether. Whereas the excluded studies are the studies that didn't meet the full criteria. Probably they were screened and they didn't meet the full criteria. Whereas we have studies that are what? Awaiting what? Classification. I'm going to expand this for us to have a more clear look at this. Then we have ongoing what? Studies. So there have been sometimes that we can actually use what? An ongoing study that just published some part of it. But for the sake of this, we'll be interested in the included studies. So I'm going to right click there. I just right clicked on included study. So I click on add study. I click on Chen et al. Next, 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 next. I click on nothing. For now, I finish. So when I click here, I see Chen et al. Now I have to be very careful. I right click again. Remember, we have already extracted our studies and I've already explained this in our previous session. So you know already how to extract all this information from our article. So I'm going to go back there next. I'm going to paste this. I'm going to go to next, 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 next. Then I'm going to finish. Then I'm going to come back there again. I'm going to add study. So come down. I just Control C. That's cool. So we're not interested. What about bleaching? This one, or this, or that, or not, or that. We're not interested in that. Next. Yeah, we're not interested in it for now. Yes, next. Depending on the study, sometimes you can put the if you want. You put on next. Click on finish. That is for what? The study by Zoo. We click on that again, right click. I'm going to click here. Next, next, next. Finish. So I can just put it up and finish it immediately. So click on add studies again. To be sure I got that clear, I click on studies and click on add studies. Okay, cool. So I selected that as included studies, probably where I'm marking. So I return back to my draft. That's a study by Platt et al. Okay, cool. I put that in, next, finish. And I think that should be the penultimate. Okay, yeah, it shows that I've already imputed it before. Okay, so sorry for that. I think I copied this, I don't know. So I'm gonna finish. So I'm going to click on that. I'm going to come down here. Just open that. So I'll click on this. I'm going to click on finish. So that is checking that here is 1, 2, 3, 4, 5, 6. So we have already imputed what? All the what? 7 studies. Now, if you go back here, the next thing now is what? Select the model. Now, we won't even select that because we need to set up our what? Comparison, our comparison what group. Now, in the sake of this, our study here, we're only performing what? One singular what comparison. We're trying to compare locking fixation techniques in managing humeral fracture compared to what other therapies. Remember that whenever we talk about humeral fracture, we're looking at it as maybe some of the common injuries that are affecting the upper arm. And most times it can be caused by falling when you fall, or osteoporosis, or maybe trauma, direct trauma, or maybe anything, right? Lots of things can actually cause falling. So, but now we want to now know Luxing fixation in treatment of that para. How effective is it? That is just it. So that is our first comparison group. So what we'll do now is we'll come to meta-analysis. We'll close this. We'll go to data and analysis. We'll add comparison. Remember, I clicked on add. We're still adding our data. Doesn't end. So we'll say locking fixation compared so we'll click on next. We'll click on finish. So now the idea behind this comparison group now is that Inside of this comparison group now, that's where we'll be having our what? Our outcomes. So in order to do that now, remember, I'm also going to explain that looking at this report, before you start your systematic review, you usually design a proposal where you clearly outline the outcomes that are going to be used in your study. This is not different from that. And when we go to the inclusion and exclusion criteria of this report, you can actually check it down. We go to the now, cool. What can we actually see from this selection criteria here? We can see that what we have the criteria, which is the PICO, we have the what inclusion and exclusion criteria. Now, if you look at the outcomes here, now let me explain it this way. Let me explain it in a more simpler way now. When we are trying to compare, remember that we're trying to know if locking fixation is more effective in treatment of humeral fracture. Now, one question should come to your brain: how are you going to know if it is effective? That means each of these primary studies here, remember these are seven randomized control trials that we've included. 1, 2, 3, 4, 5, 6, 7. So the first person tried to look at proximal humeral internal locking plate combined with a custom neutral position shoulder and elbow sling for proximal humerus fractures. The second person looked at prolaxial locking plates in treating distal humerus fractures as a comparative randomized control trial for clinical outcome. The third person looked at locking intermediary nails and locking plates in the treatment of two-part proximal humerus for surgical neck fracture. Fourth, also looked at the treatment of proximal humerus fracture using internal fixation. So all these internal fixation and all these things are still synonyms of locking fixation. So this looked at locking nail versus locking plate for proximal humerus fracture in an elderly population, a prospective randomized control trial. Whereas this also pays very full attention to locking compression plate fixation versus intermedullary nailing of humeral shaft fracture. Which one is better? A single center prospective randomized control trial. The last is locking intermedullary nail compared with locking plate for 2 and 3 part proximal humeral surgical neck fracture. A randomized control trial. So what are we saying now? When you go through all these papers, right, for them to be able to ascertain anything, there were some data that they did what? They extracted. Now let's look at this one now, like here now in table 1 for the first article. We did extract what? We did extract baseline characteristics of the patients, VAS, right? Consistent shoulder function score, the post-operative definition, dysfunction and failure of internal fixation. So all these things are all data that are relevant to be extracted, because remember that in our explanation of a meta-analysis, we said that a meta-analysis tries to combine the overall estimate. So it means that we did list all the what? All the outcomes. You must list all the outcomes first, whether they are under the primary or secondary outcomes, or whether you're not even classifying them as primary or secondary, you're taking note of all of them, then that is fine. So that means in terms of our primary outcome, we have the functional outcome, we have the fracture union rate, we have the complication rate, we have the pain, range of motion, dash score, and radiological fracture healing. Now let me explain these outcomes, sorry, so that we get to even know what they are, so that it doesn't confuse us. Because our sole purpose is to One of our sole purpose is to do a meta-analysis of local fixation techniques in managing humeral fractures compared to other what techniques. So this is what we are really concerned about. So in that situation now, what functional outcome means is a type of continuous outcome that assesses shoulder functionality, particularly during post-surgery. It combines pain, daily activity, range of motion, and with higher scores, indicating better function. So this is something that is measured in what? Decimals, so and numbers. So it's a continuous what? Outcome. Whereas for the fracture union rate, is also another outcome that we're going to try and look at across all the studies. Right? It's a binary outcome, and it's an outcome that it refers to whether the fractured bone has successfully healed or united. It's a binary measure, simply noting the presence or absence of the union. The next one is complication rates. It records the presence or absence of compilations such as infections, implants, and all that. So all these things are all the outcomes that these individual studies measured on. Please, if you're listening, do understand that the very first thing you need to start your meta-analysis is your outcome. Without the outcome, there's nothing like meta. Meta-analysis does not exist because it is those information that you extract from those studies, those specific information that are standing as the outcome, that you will use to perform your meta-analysis. So if you don't have the outcomes, it can never exist. So another one is the pain. The next one is what? Range of motion. And the last one is going to be what? The DASH score and the radiological fracture healing. Now, did we just go like that? No. Now, what does it mean? What it means now is that these are our primary outcomes. The first three are our primary outcomes. This one now, functional outcome, was measured in what? Continuous what? So measured in what? Continuous what? Variable of continuous outcome. And we found it in Chen, Zhu, Platt, and Gressel. Now let me show a demonstration of that. So that means when we come to cool. Now when you look at this now, Chen, let's have a look at this. Just pay close attention to this particular outcome. We'll find it in Chen, Zhu, Platt, and Gressel. Function outcome. So we'll come back here. Chen, here we have okay. Constant metric score. So this is it. Right? Now we move to the next, which is standing as a functional outcome. We move to the next one is Zhu. It's also here. I hope you can see it. Then that means when we now open those papers and search for them, we can get some of those numerical attributes. Or even if we get it, we can still just put it in the table. It's very important. Then, so the same thing actually applies to all the domains, right? So if, like now, for example, now you want to see range of motion is in the what? Continuous what? So that means when you look at these three papers, you're going to see that they reported the information about it. So this makes it more easier for us. So it means that all we are going to be extracting data and papers that are here, and it's going to be what? Small straightforward forward. So now in that scenario, in that situation, what we are going to do now is, since we've already seen all the type of outcomes and the studies that are reporting nature of this outcome, because we did not just come up with data, we didn't just cook up with studies. to show off or whatever. No, what we are doing is we pick up some of the included studies from the selection process, then go through them thoroughly. We already have the outcomes stated earlier in the eligibility criteria. We need to pick up all those studies and extract the relevant what data. Now, to get that done, based on functional outcome, these are the what? Remember that it's continuous. These are what the numerical numbers that we got for what? For that article. Now, what are we now going to do? So coming to this now, this particular comparison group. Remember, I identified this as a comparison. I have to click on it. We're going to add an outcome for it. Now, how do we add the outcome? I need to go back to explain this because already technically we already understood everything we need from this table and this synthesis. So to add outcome, now remember I've extracted all the relevant information, but let's just go ahead so we will understand it. So what is my outcome? Remember, I already stated it here. So this is it, continuous, right? So we come back here, we click on continuous. So we're going to enter mean, standard deviation, number of participants, experimental and control group. So we go to next. Now, what are we going to name our outcome? The outcome name is here already. So I could just copy that, paste that. So group one label is going to be experimental. Or it can be what? Whatever thing. So we can call it rotten fixation and other techniques. So we'll move to next. Now remember that here we did mention clearly that we need to select our what? Our effects model. So we need to now come back, select random. Why are we selecting the random? We're selecting the random because there are some differences that we observed, particularly when we looked at the what? The characteristics of the what? Of the included studies. There are quite some differences that what? That has been observed, particularly in terms of the outcome reporting. It's not like it is very consistent across them. At least when you look at this, you see that there's a lot of inconsistency in that. But that's by the way anyway. So our effect measure, we choose the what? Mean difference. So go to next. So based on our plot, we can call this blocking fixation. Right? And this is favored what? Control slash others. Right? Now we leave this blank. Any units of effect measure, we leave it. Scale 100. Study ID, we leave it. We'll go to next. We'll finish. So it means that all we need to do now is to do what? Is to extract all this information in terms of functional outcome. Go through the what? We need to go through the 6 papers, 7 papers, and check out all the papers that are reporting on that particular term. Do you get? Then we'll now extract all the relevant data, statistical data from those papers. Right? Now, but to make this session much more easy and simple, I've already extracted all the information that we need. So what have we done? Based on the functional outcome for these 4 studies, remember there are 4 studies here. We have done what? We've extracted the mean, the standard deviation, the total. Remember, if you look at this now by chain, when they're asking about this total and total control, go back to the characteristics of the previous studies. Here, group A is what? 56. Group B is what? 56. So that is what? The same what? Total we have here and total we have here. So which is basically the people and the participants that participated in the study. So what we'll do now is this. It's very simple. We now need to add the studies. Okay? So how do we do that? We return back to Revman, right? So we'll click on, based on that outcome, functional outcome, we'll click on it. We have chain there. I can hold the shift button for chain. Then I go back. The next person there is what? Zoo, flat and gray city. So I'm going to go back, hold the shift button, zoo. No, that's the control button. Chain, flat, and so now having that, I'm going to just click on finish. So it brings this to me. So all I need to do now is to now enter the data that I've got. So how do I do that? So simple, I'll just copy this. So I'm trying to transfer it there. I just got this well copied. So I'll just paste it here. And instantly, my forest plot is out. So I'm going to just shift this a bit. Then I can still shift this. Then remember, it's the mean difference. That's my weighting. And so we'll just click here on forest plot. Remember, we're using mean difference. Mean difference. So we'll click on. So I want this to be first control or others. Still cool. So I'm going to close that. So I'm going to come down here. So for the first outcome, I'm just going to put the meta-analysis there quickly. So this is primary outcome. I could just name that so let me just tie to the table once. I'm going to call this figure 1. I'm going to call it forest plot showing the effectiveness based on okay, cool. Now, how do we write the results? I think we'll have to put in, let's put in another forest plot, then we can now write the result. So that will be enough for us, particularly since we already have all the necessary data. So how do we go about the next? We return back to data analysis. We come here, we click on add outcome. Now remember that our second outcome here is a more like a dichotomous outcome. How do we confirm that? We return back to our table here and we talk about fractured rates dichotomous. So we now know that I will have these 3 studies to add. So I can now come back here to Revman. I'll leave it at dichotomous next. I'll just name it. I'm trying to name it. I'm going to click on next. Random effect. Inverse variance. Now, remember what we explained about the risk measure. Now, let's read what this means also. You see, it tries to refer whether they are successfully healed or not. It's a binary measure, simply noting the presence or absence of it. So, I think this is more like the odds, right? So, the odds. So, we can use what? Odds ratio. Okay. So, we leave it at that. So, click on next. So, you can see favors order techniques. So we need to keep it right because of how we arranged our table. So please be very careful so you don't make that mistake. So we're going to keep locking fixation here. Because of how we arrange our table. So keep on next. Boom, finish. Now remember here, the next thing we'll do now is to add these studies, right? So we need to add. Let's add these studies. By Crawling, Ziegler, and Acton. Remember it. So what we'll do, click here. We'll click. So click on finish. So this is it. So the next thing we're going to do now is we're now going to queue in our data from this. Remember that we left that at the right label because of where our event is. So that is what we need to understand. So if somebody might be asking, what if we change it to bring it here? It's still the same thing because wherever you keep it, it's still the same data you're going to put there. So we've inserted this, right? Then, no, not for that. That was for this because of the position. Here it's down. So this one is going to be normal. CZ. So we've got that done. So this is it. Now, so we could go on and on to get all the forest plots done. So I'm going to elaborate this figure too because I believe we have the Prisma flow diagram up there. I'm going to call this figure 3. Now, so I think this too is cool and enough for us to run our example. Let me do one more. So these are how we'll keep generating. So to get that done, we come here, we right click on the comparison group. Remember, we have just one comparison. If we have plenty, then that's where we can do that. So the next one data, the next data type, we look at our rough work here is still dichotomous for complicated rates. So we move next. Complicated rates. So this is group 1, group 2. If you want the first one to be other technical, you can change it here. So it's going to be random effect. Can leave that, not really much effect. Can always change that. So we return back complicated rates. So the risk. So we can use the risk ratio. Next. We don't touch anything here. Next. So we touch nothing. Next, you finish. So get that done. How many studies do we have for that? So complication rates. That is 0 plants and grasses. So we turn back there. We come here, we click to add the studies. That's by 0 plants and grass. I think I got it correct. Now, it is arranged in alphabetical order, so you have to be now very careful while you're copying. Now, somebody might ask, how did we get all this information? We got all this by doing what? By reading the articles one by one. Then when we go to the results of the abstract, we try to extract one or two information. Okay, cool. So here, this should be the first. We'll copy that. We'll come here. So we're gonna copy this one to pull. So if you look at this one now, it somehow it favors locking fixation, right? So that is how the chart works. So I'm going to copy that. So this is going to be congratulations, we have successfully performed a meta-analysis. Now, what will be the next thing for us to do now? The next thing for us to do now is to do what? We'll do the same thing for the other studies. I think I can get the remaining 4 done immediately, quickly. So let's take out that secondary report. So let's just put that in so that we can. Okay, so we have pain and radiological fracture healing. So I'm going to also put that inside of there. Okay. These are some of the secondary outcomes. So how do we go about that for pain? So we still return back here. Remember that pain is now a continuous outcome and it's got 3 studies. So I'll take this out immediately. So don't have any confusion. So we'll just basically, this is for pain, it's continuous, looks at churn, zone outcome. So when I want to say, okay, how could I still look at this? Yes, you can, sure. When you hover around the what? The characteristics of impedance study. I zoom, look at it here. Come on, that. Flat, pin, grassy. So it's clear. So to work for pain, all we need to do is still to enter into Revman quickly, right click, add outcome, instead dichotomous. What's the name? Take that. Next, random, whichever. So the pin, the odds of pins, so can use odds ratio, and next. Vacuum fixation. Other techniques. So, okay. That one. So I'm going to come here, I'm going to open for that. So we go back here, Chen, Zoo, and Aka. So we'll do this, Aka, Zoo, and this. So I use Shift to do that. So I'm going to put that on. So I'm going to just copy this first. So put that. Okay, I think no. I think it's wrong. It's wrong. This is continuous. So that's a mistake. So what we do is we close it, we take it out. Delete outcome. So delete it, come back, we click, we add it again. That's continuous. Made a mistake. So we corrected that. We put it back again. This is continuous. Put next. Random. Still a mean difference. Inverse variance. Next. That's mean difference. Now remember that I did mention already when I was explaining that mean difference and this only works for what? Only work for what? Continuous outcomes. So I already said that. So we don't need to touch anything here. Movement. So we're going to say this favors lock-in section. And this is what favors dot techniques. Or like say other techniques. Sure. That also seems cool. And that's cool. Finish. All right. So we'll come here. Archive, chain. No, we didn't get that. And zoom. So put it in. So here we come here, we'll pick the variable for alkaline. Put it in. For chain and zoom. You can copy both. Control C. I just copied that to make it faster. Click on. So it still favors locking fixation. That is what we're interested in the first block. Yeah, I think we can use a fixed model because of the similarities in some of the study. But regardless, it doesn't change anything as much because of the position of the diamond. So we'll put that in quickly for pin. So the next one is going to be range of motion. Slide down, it's still continuous. We exit this, come here, right click, add an outcome, continuous, next, range of motion, so next, fixed effect. Leave it to random. Next. Next. So okay. Decision. Next. Finish. So check out the studies that are included for range of motion, frontal, flat, and gradual. So we can actually get that clicking here. We click on this, we hold the control key, this and this. That seems nice. Like it was just a straightforward selection. So we go back to it. Copy for this. Remember, our data extraction is done by reading the full text of the article. That is the only way we do our data extraction. So return back there. I'll take this. I think this favors other techniques. Okay. So we're going to pick that. Okay. Now looking at the dash scores is very important as well. It also seems to be what? Continuous. So what we're going to do is still simple. We come out here, we come to this, the intervention. Remember, this is the intervention. We have another intervention with several outcomes too. So we click on this, we add outcome, it's still continuous. Only the dash scores. Move to the next, random, next, next. Local position. Next, finish. Now to be sure, when we look at dashboard, we have Ziegler, Ackerman, and Grasson. So we come back here, we check Ziegler, Ackerman, and Grasson. So that's it. So we come, I think we can take these two. Then so we'll go to the last one, which is radiological fracture healing. We'll check it out. And it's dichotomous. So we're going to continue with that hit. Go to the next. So I think we'll leave it at. Sorry about that. Impact variance, and it's going to be okay. So this is going to be So finish. Now check out that. I think here then we got two studies, Cronley and Ziegler. So we need to move then because remember that a meta-analysis can only be performed with at least two studies. One study alone is not enough for meta-analysis. That's also important to note. Just a symbol into your thesis where you must include at least two things. So it also applies meta-analysis where we must have to include at least two studies minimum. So I think it's also found a very good avenue for me to actually explain that. So technically we are there and we've got that trash that. So remember, if you pay attention here, you see that we've run the analysis. So it's time for us to interpret the results, right? Cool. And I really made us understand when we need to use some of these effect measures. I did explain that in the previous lecture. And I'm going to write the result for this now. So if I write the result for this, what we can say is, because we need to interpret this so that it can be something that we'll discuss. Just like as I explained, here we have standard mean difference here as 0.06. Now, before I do that, I'm going to show some samples of some of the things that I've already done in this activity of in quantitative systematic review meta-analysis of effectiveness of combination of antiretroviral therapy for TVs / HIV co-infection, where I compared efavirenz versus integration inhibitors. Now, if you look at here, everything was done, the data extraction, so strategy, and the ethics, the results, as usual. 5 studies were included for the meta-analysis, and the criteria of the studies were clearly stated. Well, we've got the outcome with the de-risk of biases in Cochrane, RLP. Now, in terms of the meta-analysis here, you see that it was a meta-analysis of co-infection, right? Trying to compare efavirenz as a drug and integrase inhibitors. So if you can see here, you can see the way the result was written, right? And we did note it was significant reduction. Some of the decisions that we made here now was based on what? The p-value and other parameters that are here. So I'm also going to pull up another example so that at the end of the day we can now compare and see all that I've done here. This is just a result. I just traveled out where we tried to know the efficacy of the treatment of lentivirus gene therapy managing sickle cell disease based on hemoglobin. So if you look at this here now, it's no difference, right? So still similar parameter we did calculate here. Trying to know which was being favored, right? So when we say there is significant reduction, that means it's negative and the p-value to show us that. Now, remember, if we can go back to our slide here, our first slide here, we see that it tries to derive what? An overall effect. So whenever we want to talk about the overall effect in meta-analysis, this is where we are interested in. I think we're done with this document about listing outcomes and all that, so I can close it. So whenever we're talking about the overall effect, we're interested in the what? In the Z. Right? Test for overall effect. So this is where we're interested in. I'm going to zoom in that. We're interested in what? In this. Always remember here that we're interested in what? To derive an overall effect. Summary effect estimate. So it's always going to fall on our what? On the p-value that is close to the Z. Now let me explain all the parameters here. This is the what? The confidence interval. Right? For this. Cool. Now, this is the total sample size across all the studies for the participants in the intervention group. And this is the total sample size of all the participants in the what? In the control group or other techniques. Now this is the weighting. Now what this means now is this implies the what? The overall weighting. Now you remember when we did mention that the box, the squares, does note the what? The weighting of the studies. I was very sure I made that actually very, very clear in my explanation where when I was talking about the weighting, about yes, I think I did explain it somewhere here. Yes, here. Right? The squares. So the more bigger the squares, the more weight it's going to be. So now let's look at this now. Now looking at this here and this result here now, this at 7.3. So apparently you can see that it has more weight than this. This is 17, this is 20. 20 is having more weight than this and this. That means this is 24. You see, it looks like it's more bigger than this. And this is the what? The overall, which is what? 100, which is overall. Now, this is what we're interested in now. This is the p-value. These are the what? Sorry, this is not the p-value. These are the upper and the lower limit. These are the confidence interval, right? For this particular what? Overall test effect. And this is where we're going to actually make what? Decision about whether there is any significant reduction or not. And if you can remember here, I did mention that, let me make it very clear now. Okay, cool. I already mentioned that whenever the mean difference is what positive, it means that what there's a significant what there's a significant effect in what the treatment group. I asked you can actually use some of these tools to actually support your what your this. Right? Whenever the mean is what's negative, it indicates that what the outcome measure in the intervention group is lower in the control group. So, but we don't really need all this. All I'm going to explain now is I'm going to put down the result so we can be able to do what to capture that. So how do we do that? What I'm going to say here now is this. So based, I'm going to start by saying based on the okay. Okay, so we can see that first is my language. And those studies were what? Chain or now we can say, okay, let's make the sentence more clear now. So based on this meta-analysis, because four studies were included as second the materials of Good. The results. Now look at the p-value here. P is less than what? 0.04. So that means there is a what? There is a significant what? Effect. There is a significant effect, meaning that what? Other techniques. Now let's return back to the definition of explanation of functional outcome, because already it's going to be very important for us to have that in mind. So we can actually make any judgment. Remember, we explained this as continuous outcome that assesses shoulder functionality. It combines pain, daily activity, range of motion, with higher speeds in skating. So all we can say here is very simple. So to interpret that, and I will say that the results reveal that so that means the diamond staying here and p-value being this less than this, it means that other techniques, this will reveal significant improvement in functional outcomes. Functional outcomes. Among the patients. So among the patients. It's working session. Right? Are we done? Now, this is what we'll now do compared to what? Locking fixation. I will now need to now report the statistics. So there is reveal significant improvement. So that means there is a p-value. So we'll see. Now remember, if you look at what I've done here already, I will mention the effect measure. Look at this also. Right? I'll always mention the effect measure. I'll mention the effect measure. Or check out this as well. So we'll see what I'm doing. I'll mention the effect measure. Then before I talk about heterogeneity. So what you're going to do now is to make sure you do mention the effect measure. So what I'm going to say is the results reveal significant improvement in functional outcomes among the patients using other techniques compared to locking fixation. So I'll say SMD equals to SMD equals to what? This I'm going to put it 0.86. Right? Now, almost 95%. Now I'll now put all these things inside here, which is what? I'll put a block. Right? Alternatively, I can bring this out as well here. So 95% CI. Then I'll now bring 0.62. The upper and lower limit 1.10. Log. Not a comma B. I can add Z as well. Z squared. Z equal to Z to 7.12. Or sometimes I add P, but most times I prefer to use P less than 0.86. 0.001, right? So that shows what? There is a what? There is a what? Significant what? Improvement in what? For patients using other techniques compared to what? Locking what? Fixation. Now, now, if that, will it stop there? No. So we cannot. So the next thing is to do what? Pull my line forward, test for heterogeneity. So now understand that for you to talk about a test for heterogeneity, you're looking at what? I squared. I squared at 0%. What does it mean? It means that what? The studies are very, very, very what? Similar, right? And that is why p value is what? Is higher than 0.05. So that means there is no significant heterogeneity. So I'll not say, however, based on the test for heterogeneity, okay, so but studies will not other it doesn't mean that the studies were consider working significant should now put a bracket I control shift plus to put squared control shift plus brings it down equals to 0% and shift 510 comma p is what equal to 0.47. So whenever there is no significant heterogeneity, that means it's greater than what? 0.05. So you see P is an I squared distance. So meaning that the studies are what? Homogeneous. So let's write the results for the next thing. So here we can actually use another approach. We can actually say, let's see, let's not just first studies related outcome first in audit first looks so let's do that. Okay. So you can cite those about this. I'm saying, oh, so good. Okay, so if you want to go for, I can say a total of so and so were involved. Like if you want to expand more on the words, or I'm interested in that. So based on this analysis, so here you see that. Remember that we said that remember what we said here during the decision about when we were explaining about this. We did say that anytime if the diamond does not cross the line, results are statistical. So that means if it crosses the line, results are not statistically significant. We already made it clear here. So that means this diamond here, from this explanation here, has crossed the line. So that means results are not statistically what? Significant. So it's neither improving nor not So show that what was mean what statistical okay. So that now we put our what our effect measure OR. Remember this is it. OR is equals to what? So we will say we will rather say that we will not the statistical significance equals to the of odds of improvement. If it is relative, you can say risk of 1%. So okay, under under what? So OR is equals to what? 0.77 bracket 95% AI will block it. It is going to be what? 0.6. Remember, this is what I'm putting on this 0.61 is a 95% CI is the 1.6, which is presenting the effect measure, and this is 61.5.12 block P. P should be greater than 0. I see it. We already P self is already greater than 0.05. So P equals 0.2. So that's the heterogeneity. So let's just copy that. So I like to cite, it's important to cite the figure. Attention to the common. So, in terms of heterogeneity, 0.97. That's very high. I score this to 0%. So, okay. This is homogeneous. That's good. So let's write the result now. So we are getting familiar with it now. We're getting the overall estimate. So based on this compilation rate, so we can say so this is complication rate. It's revealed that rate. So here now for the complication rate now, look at it. The risk of improved the reduced risk of Patients. Affect. So you put RR is equals to what? 0.5. Right? Then we now put what? 95% CI. What? 0.28. So put 0.96. So it means that locking, locking physician reduced complication rates compared to other therapies. Hmm? Well, based on the test percent, it was revealed that there was no there was no I hope that wasn't the rest. There was no there was no please whenever the I squared is less than zero, that means there is no heterogeneity. Heterogeneity means when it's greater than 50% cutoff, just as we've mentioned already in our literature here, because in our results, in our synthesis, we did mention it. I'm going to go over there now quickly so it's we don't complicate things. But remember here we said it. That's it here. So this is so you mean the I squared heterogeneity was capped at if it's less than 50%. So the studies were less likely to be heterogeneous, and if then it was noted to be heterogeneous. So that is it. There is no what heterogeneity. And the studies are homogeneous. That is what we did what we realized. So okay. So that is the complication rates. Okay, so we keep moving ahead here where we so this is going to be for danger of motion. We're almost there. Okay, cool. So the same thing also applies to our mean for pain. Here we'll still make almost a statement, but here we just need to how to get it more faster. We can say that as So same thing here. I mean, difference. So because it's negative, here we say it was less likely to. So put minus 86. Remember that's the rule. I will not say minus 1.5. And so because once it's negative, then it has to be less likely in the intervention group. So 0.48. Right? So the P is still very less than 0.8. However, based on the test we're creating, there was not significant achievement. 72% is, so remember our cutoff is 50 and 0.27. So I think we're done with that. So the next, to the next. So just copy this, then change it a bit. So right here. I think there's some things we didn't remove. Okay, for this one. So here now, remember how we defined the range of motion here? Would you define it as the extent of so sometimes we can actually decide to pull it into to reduce put it the extent of movement in that pretension. If it's in the um, so I've technically just brought that to substitute it. So this is going to be equals 6. The its mean difference, but there's no negative there. It's still 5.56 minus 5. Then we'll have 12. So that's still returns its value. Same here as well. But this is going to be 8.01 here. I got it here. And this is going to be at home. So that's it. So if you want to explain that more in detail about dash score, so we're still doing we're getting to the end. So for this dash score, for the dash score, what we're going to do is we're going to just bring back to this. I'm going to so that cross-trace studies that so it did improve it, locking fixation. So you can see it here. The foil is supporting this. And now what we need is this. Right? So we're going to just put that empty then equal to minus 2.87 and then block it as what minus 4.49. Okay, for that, come back to put 5% back orbital bracket. Yes, that. Okay, please just equal to 0. Zero 0.41. Okay, so that was what? 0. Remember, I squared is less than 0. So So I think we'll just put that still. We're just cool with it. I'll look at the outcome of radiology. So yeah, there was no significant because of the it touched it. So we can actually bring this to that, and it's still the dichotomous. So consider based on the mechanism results, there was no statistical significance as the odds of improvement in. So this is going to be 0. Okay, so OR is equals to 1.869551. This is what I'm taking. This, it's this. 6.77. Okay, so I squared is 0 and it's 3. So we've got to retreat. Well, the p-value is what? 0.45. That's mathematical analysis. So the next thing is going to be we need to discuss what's your result. Now, I'm going to just a summary of what we've done in this detailed session, because this is just technically the only lecture that you've got for this particular amount of time. Trying to get it done and doing as much as possible of the right thing. Alright, so now to make it more clear, like I said, this is the confidence interval, this is the effect. This effect measure is the upper and lower limit, and this is where you make your decision, right? Whatever p-value you have here is your overall test that we did define. Anytime we define our what or meta-analysis as overall effect, that comes from your what, from the value from your what, from your z-squared. So that's the test for overall effect. So if this is less than 0.05, then that means whatever thing you're trying to compare itself, there is significant effect, or there is statistical difference, or the whatever thing, right? So that is it. So I believe if you go back to some of the videos which you have made, right, to follow up again, you're still definitely going to understand everything that I have done. Now, so let's go back to how we got to start this session. So we can actually round up. Now, remember we started by talking about meta-analysis, and after talking about that, we did mention the various effects. In effect models in meta-analysis, I'll talk about the types of outcomes, talk about the key effect measures in meta-analysis, we talk about the step-by-step guide in conducting a meta-analysis using Revman. We also showed how Revman interface, some of the workshop, Revman interface, that we talk about forest plots, publication bias, funnel plots, interpreting your meta-analysis results, some of the additional components for meta-analysis considerations whenever you want to start. Now, we did mention about meta-analysis as in statistical technique that combines results from multiple studies. We made the earlier example when we talked about combining two literature around malaria, where you want to combine everything all the information about malaria maybe in a setting, then to get a pooled estimate. So we made all these things very clear, and we said that the idea is that without the meta-analysis, it will be very difficult for clinicians to make decisions. And that is why most of these publications from great literature, the WHO, archive, are all drawn from a meta-analysis. Now, we talked about the various effect models where we said we have the fixed effect and the random effect model. And we said for the fixed effect, it's just assuming that all the estimates have the same effect. And for the random effect, it is kind of it varies in the estimate. And these are all the things we looked at for the fixed and random effect. We said that for the fixed effect model, it's just like an ice cream, everybody's testing the same ice cream. And for the random effect is where everybody's testing different ice cream. So in that situation, now there are differences in experience. We looked about the types of outcome, which the primary ones at the stage is dichotomous and the numerical outcome, right? So it depends on the type of data that we have that is going to influence how we're also going to use other interface. And all these things were explained in the what? In the SPS, it was explained in the review manager. So we have the odds ratio, which I talked about, and the risk ratio also, which also made very clear when to use them, the differences between the odds and the risk ratio, when you need to opt for the risk ratio and the odds ratio, depending on the nature of your research. So we'll talk about the mean difference, which is usually dealing with continuous outcomes, wherever it's out continuous. Whereas for the odds and risk ratio is for what? Dichotomous outcome. I'll talk about the standard mean difference, and which is also very imperative. We put it, right there. And we also made mention about the differences between the mean difference and the standard mean difference, where we made mention that for the mean difference, right? Yeah, it's usually when you're trying to know the absolute difference in the means of two groups. Whereas for the standard mean difference, you're trying to get a standardized account from different measurements. Because these are some of the challenges we face severally. In a way, you're trying to measure a particular outcome and it has several scales. So you need to actually convert and use what is standardized ones to measure. So walk us through Revman, how we can use Revman, getting started with Revman, importing your articles, getting your studies, then selecting, interpreting, making your results, and some of the various sections that are contained in the review manager software, and the interpretation of the forest plot and the publication bias as well, the forest plot. So to get going there already, we talked already about what some of the things you need to consider when you start your meta-analysis, which is not different from your systematic review. Identify a clear objective, select your studies, assess heterogeneity, model choices, and all that. Get an example. So other areas that we also need to look out for is the I-squared p-value, subgroup analysis, sensitivity analysis as well. But those are actually done when there is need for that. So what is some of our key points for today? All we can say is that for meta-analysis, it combines data for a summary effect, which we talk about equal z-squared. Revman is a very powerful tool that you can use for meta-analysis, you can use for network meta-analysis, you can also use your R software, you can use your SPSS, you can use Python, they are very useful. You will always need your forest and funnel plots because they will help you in your interpretation, because those are basically what I used in my interpretation, and funnel plots are for publication bias, and also good interpretation and writing of your results is going to make it very decent for your discussion. So thank you very much for this section. It's a very massive pleasure to have you walking through Revman for I think about 3 hours or more, and we look forward to the next session where we talk about narrative synthesis, which is a very decent area. You can also use some advanced method in supporting our narrative synthesis and getting it done quickly. So, thank you. It's a very massive pleasure to have you guys here, and I want to say a very good thank you for staying to this very end. Thank you.